Faiz Shariff, and today we'll be diving into advanced techniques of converting a Roux-en-Y gastric bypass to a SADI or a DS. Joining me today is my co-host, the brilliant Dr. Juyeon Park. Next slide. Before we jump into today's discussions, I have a few announcements. First, a reminder that Bariatric Happy Hour is held on the fourth Thursday of every month. This is where we discuss sentinel papers and advanced surgical techniques. Our next meeting will be in October, on October 24th, where we will be exploring the feasibility and outcomes of metabolic and bariatric surgery prior to neoplastic therapy. Also, don't miss out on our Fellows Project webinars, which is held on the first Friday of each month. Our next session is on October 4th. The topic is titled, If You Build It, They Will Come. And looking ahead, mark your calendars for FASMBS weekend meeting, which is from 7th of November to 9th. Very exciting topics there. And prior to that is our Leadership Academy. This is a unique way for fellows to kind of get to meet our FASMBS leadership. And lastly, for those fellows that graduated last year, please remember to submit your fellowship certificate application for your FASMBS certificate. Now, let's start today's exciting discussion. I feel like I'm missing something. Oh, yeah. The deadline for FASMBS START program has been extended. So if you haven't sent in your application, I urge you to send that, because this is a year-long program where you learn robotic surgery from experts in robotic surgery. So now moving on to our discussion. It's a pleasure to introduce our guest today. He's a good friend of mine, Dr. Folahan Ayoola, a distinguished and highly skilled surgeon with an impressive background in metabolic and bariatric surgery. Dr. Ayoola earned his bachelor's degree from the University of Houston and completed his medical training at the prestigious UT Southwestern. He went on to complete his residency and fellowship at Virginia Commonwealth University, where he honed his expertise in minimally invasive and bariatric surgery. Dr. Ayoola practices at several renowned institutions around Dallas suburbs. As an expert in robotic surgery, Dr. Ayoola serves as a proctor and a trainer for intuitive advancing the precision and safety of robotic surgery, especially for advanced procedures like SADI and DS. How do I know that? Well, he proctored me. I am one of his mentees, and I'm grateful for that. His contribution extends beyond the operating room. He is a recognized speaker for FASMBS, multiple weight loss, pharmaceutical, intuitive, and many more, too many to list. As an active leader in the field, Dr. Ayoola serves on various committees, helping to shape the future of the specialty. On a personal note, Dr. Ayoola is my go-to guy, my caller friend when I'm in dire situation in the OR. His sharp instincts, problem-solving expertise, and willingness to lend a hand make him not just a trusted colleague, but a reliable ally. Dr. Ayoola's dedication to patient care, innovation, and physician education makes him a respected figure in our field and an exceptional leader in the fight against obesity. So welcome, Dr. Ayoola.
Thank you so much. You are so kind.
We also have
that and more. I could keep talking about that. Our next speaker, Dr. Park, do you want to introduce him?
Yeah, can you guys hear me?
Yeah.
Okay, so we have our fellow, Dr. Danny Poon. He got his bachelor's degree at New York University and went to medical school at Drexel University College of Medicine, Philadelphia. He had the lovely pleasure of doing residency with me at Stony Brook University Hospital, and now he's at New York University, Long Island, and he is about to be a dad in just earlier. We don't know. He's going to be presenting for us.
All right, I'm going to share my slides. All right, can everyone see that? Great. Thank you, everyone, for giving that kind introduction, also giving me the opportunity to present today. So I want to kind of just touch base on a couple of things today, specifically just the basic Roux-en-Y gastric bypass, the biliopancreatic diversion with duodenal switch, and also the SADI procedure. And also, lastly, just what current data and outcome is out there regarding specifically conversion of bypass to these procedures. All right. So the Roux-en-Y and gastric bypass, the duodenal switch, and the SADI procedure are both restrictive and malabsorptive procedures, all endorsed by the ASMBS for weight loss. Has been estimated that close to 200,000 procedures, bariatric procedures, are done on a yearly basis, with the vast majority sleeve gastrectomies. Regarding indications, as we saw from last month's happy hour in 2022, the SMBS and the IFSO did publish updated indications for bariatric procedures or surgeries. It's now indicated for adults with a BMI greater than 35, really regardless of presence or absence or severity of comorbidities. And with patients with a BMI of 30 to 35 with metabolic disease, in these patients who have failed non-surgical management, you really should consider metabolic surgery. So moving on to the gastric bypass, it's characterized by a small gastric pouch that's divided, separated from the distal stomach. The BP and roux limb of the small bowel can range anywhere from 75 to 150 centimeters in length, and most of the major digestion and absorption of nutrients does occur in a common channel. The ideal length of these limbs, the roux, BP, and common channel, have really not been determined. The mechanism of weight loss, there is both a restrictive and a malabsorptive component. It does inhibit also gut hormones such as ghrelin, which are secreted in your stomach and duodenum. Ghrelin is an appetite-producing hormone, and when it's reduced, does help contribute to the characteristic loss of appetite and post-op in many of these patients. Expected excess weight loss approximately 70% after 2 years. And at 5 years, sustained weight loss ranges anywhere from 60 to 70 of excess weight loss, excess body weight loss, or 35% of total body weight. Moving on to the biliopancreatic diversion with duodenal switch. This is a partial sleeve gastrectomy with a pylorus preservation. A roux limb is created with a really short common channel. In the original procedure performed by Dr. Hess, the entire length of the small intestine was actually measured, with the alimentary limb approximately 40% in length of the total small bowel length, and then the common channel was only 10%. There is a combination of a restrictive or malabsorptive procedure, and there is also some contribution of altered hormone production, such as ghrelin, does appear to be suppressed. Now, for the duodenal switch, it was developed after as a pylorus-sparing modification of the original procedure, really intended to help decrease the high rate of marginal ulceration, dumping, diarrhea seen with the original procedure. However, unfortunately, there is a significant risk of long-term malabsorption, and it's typically used with patients with severe obesity, anyone with a BMI greater than 50. Expected weight loss is excess weight loss is pretty good, anywhere from 70 to 80%. The SADI's procedure with the sleeve gastrectomy is relatively new, developed in 2007, was developed to help reduce the side effects of this duodenal switch. Has been endorsed by the ASMBS as an appropriate weight loss procedure. It's a variant of the duodenal switch, but that only has one anastomosis. The sleeve is typically created first, and then the duodenum is divided about 4 centimeters from the pylorus. And then the transected duodenum is the anastomosed to loop of distal small bowel. Common channels created with at least of 300 centimeters with an excess weight loss of about 85%. Given the one anastomosis, there are fewer leak complications, episodes of bowel obstructions, and internal hernias. Unfortunately, these patients do suffer from chronic diarrhea, ranging for about 0 to 4 loose episodes of loose stools daily. Now, moving on to specific classes of obesity, the Roux-en-Y gastric bypass may not be actually effective for patients with a BMI greater than 50. These are patients in the class 4 and class 5 obese categories. In 2022, Maroon et al., he did a retrospective study of about 500 patients with a BMI greater than 50 who all underwent a bariatric procedure. At 5 years post-op, he did note that patients who had a switch did have a higher total weight loss when compared to the gastric bypass and the sleeve. They did actually show that the duodenal switch is also superior in resolving metabolic derangements for anyone with a BMI greater than 60, but they did have a higher rate of complications. So unfortunately, up to 35% of patients who have or undergo a gastric bypass do have an excess weight loss of less than 50%, often prompts these patients to seek and undergo a second procedure for further weight loss. And we know that we have seen failure rates higher in the super obese, anyone with a BMI greater than 50. Often there's really no anatomical reason for weight loss failures, but in some cases, a failure can be due to dilated GJ, dilated gastric pouch, or a GG fistula. Non-anatomical reasons, maybe nutritional concerns, abnormal behavior, or even overeating. There's really not much data out there, mostly single-center case studies with a low sample size. I wanted to conclude my presentation with a couple of studies I found. First one was in 2016. Here, Swerve et al. Did publish a retrospective analysis at a single-center institution. He did find the study consisted of 32 obese patients who had weight loss failure, defined as not losing greater than 50% of excess weight loss. 9 patients had a switch, and the 23 patients had a SADIs. And at 2 years post-op, he did note an excess weight loss of about 56%. In 2020, Moon et al. Did publish another retrospective chart review of 15 patients who had a conversion due to weight regain. Here, 10 patients had a bypass converted to a SADIs, and 5 had a bypass converted to a duodenal switch. Also showed that at 24 months post-op, total weight loss was about 25%. They did note that the rate of weight loss was faster for patients who had a duodenal switch, but again, limited sample size was one of the major factors. Now, in 2023, Demirol did publish another single-center retrospective study. Again, only 17 patients. All of them had bypasses that were converted to duodenal switches. All these patients were considered to have failed gastric bypass with a BMI greater than 35 at the time of conversion. And the average BMI at the time was 45 for these patients. They did note an average excess weight loss of about 74%. Lastly, I was able to find a systematic review and meta-analysis published in 2021. Here, the authors did find 41 published studies. They reported a total of 1,400 patients that were revisional procedures. Procedures included a duodenal switch, a SADIs, gastric pouch, GJ resizing, distalization of the Roux-en-Y gastric bypass, along with banding of the gastric pouch. They did note that at 1 year follow-up, patients who had the distalization of the gastric bypass had the highest decrease in BMI. But after 3 years, they did note that patients who underwent the duodenal switch in the SADIs ended up having a highest decrease of BMI. That concludes my talk. These are my references, and thank you for your time participation.
Awesome. Thanks for summarizing the data. Dr. Ayoola, do you want to take it from here? We would love to see your videos. And
I'd be happy to. Thank you. I appreciate the opportunity to speak with you all. I noticed no one's having drinks in hand, even though this is called happy hour. This is, I'll throw up a few slides that just talk about why I do Roux-en-Y to DS, and then we'll get to the video. I think the data has kind of been discussed already, so I won't spend too long on this part. So gastric bypass for a long time was kind of considered the gold standard bariatric operation, even though the sleeve overtook it in terms of volume being done. For a long time, gastric bypass was considered the gold standard. But weight regain was very common with gastric bypass. Here's a study. It's relatively old. I can't believe I'm saying that about 2006, but here we are. Looking at 10-year follow-up of gastric bypass. One of the interesting things about this was that it looked at results for what they consider long and short limb gastric bypass. And it was interesting that what was considered short limb was 40 centimeters with a 10 centimeter biliopancreatic. Nobody does that anymore. And but there was a period of time where that was considered a reasonable thing to do. There was no difference noted between the long and short limbs, which I think is incredible. Essentially, you could get away with doing 40 and 10 versus 100 and 100, and you'd still have the same long-term results. I don't think you start seeing a difference until you're doing anything over 150, and I think that's pretty interesting. But going back to the original point, there was shown to be increased in weight regain in these patients at 5 years and at 5 to 10 years. In particular, patients that had a BMI over 50 showed an increase in weight regain at almost 35% compared to folks that had a BMI less than 50 having a 20% weight regain rate. So here was the bottom line of this, that the limb lengths did not impact, at least up onto 100 BP and 100 Roux, and significant weight regain occurs continuously in patients that have a bypass, in particular if your BMI is over 50. This was another study that looked at the same thing. The bottom line here was that the failure rates approach 40% when BMI is over 50. And here they had the Roux limb at 40 to 50, the BP at 40 to 50 with 100 to 150 Roux limb. So even with a quote unquote long limb, obviously not over 150, but a longer limb, you still had a pretty high failure rate. 15 to 40% failure rate depend on BMI. If BMI is over 50, you're looking at 40%. And if you have a Roux limb that's less than 150, your bypass results are pretty much uniform. So gastric bypass, is that your king? And so the question is, what do we do if you have a patient that has had a bypass, or in particular had a BMI over 50 that had a bypass, and now they're coming back with weight regain, which is completely expected and could very easily be anticipated. So the biggest question is, bypass to DS, is it safe? There are a few studies that I will just briefly go through looking at that. This was by Michel Gagne, unknown guy. I know nobody here knows him, but I'm tongue in cheek, so he doesn't come after me. But obviously a giant in the field looking at this. And what they looked at was 12 patients for analysis, converting bypass to DS. No patients died, no leaks developed, and they saw really good results. Patients had a BMI drop to 31, excess weight loss 63% at 11 months. And so they felt like it was acceptable morbidity. One of the things they did note was with their technique, they use a circular stapler in some, and they use a linear stapler in some, and hand sewn in some. Before I get to that, the initial BMI of these patients was 53 on average. They dropped down to 31. That was their lowest post-bypass BMI. And then they went back up to 40 and then got a DS and dropped back down to 30.7 at about 11 months after their DS. So it is effective in helping those patients lose weight. So here is what I was talking about earlier, where you see stricture when you use the EA stapler, which was what they used the most. Linear stapler was probably the best way to do it. Hand sewn also still had a stricture rate that wasn't as favorable. So they went ahead and also compared all the options. Back in those days, endoscopic sclerotherapy was being used. People were revising GJs to make them tighter. People were throwing bands on these. People were doing pouch reduction, redo of the GJ, and all these things had very soft results, 3, 6, and 4 BMI drops, which weren't really fantastic. Conversion to distal bypass was done. They did 50 to 150 common channel. I do not recommend 50 common channel on distal bypass. The data says that if you're going to do a distal bypass safely, you're looking at having a 400 total alimentary limb length with at least 150 or ideally more on your common channel. So as you would expect, the 50 centimeter common channel on the distal bypass just was unacceptable morbidity, mortality. And you had as high as 25% protein malnutrition development if you had a 150 or less common channel. When you compare that to the DS, you're going to see about 3% malnutrition rate. And so that was one of the main reasons why I didn't like distalizing patients, because to get the results that would compare to a DS, you gave them such a high rate of protein malnutrition. So it didn't quite make sense to do that, and conversion to DS was better. So you showed this, I think, already, DS conversion for non-responders. So I won't go through that in detail. 250 centimeter total alimentary limb, 125 common channel was what they did. And they had pretty good results, again, with patients losing weight after that conversion. And so ultimately, this is the last study I think I'm gonna do before we go to the video. But the bottom line of this study was DS was where you would see the best weight loss when compared to distal Roux-en-Y, banding, pouch revision, or any endoluminal techniques. And this just shows the same thing again. So interestingly, the conversion to distal Roux-en-Y, they say, is relatively uncomplicated. And so that's what they think ought to be done. But it states here that the conversion to DS had the excellent sustained weight loss with low complication rate. And the only problem was, unfortunately, only a few centers performed the procedure. And so to me, the takeaway there is that the DS is the right thing to do, but we don't know how to do it, or we don't do it a lot. And so to me, that's not the best way to approach it. I think that if that's the issue, then we need to get better at it. We need to train better at it. We need to train fellows and residents coming up on how to do it. Because if it's the right thing to do, then we just need to learn how to do it and learn how to do it well. That's my opinion. So I'm going to humbly offer how I do it. This is old technique. And I think that, this is an operation that routinely humbles me, which I need a lot of. So I will always kind of make adjustments to it to try and push towards that complication rate of 0. Hopefully we'll get there someday. So this is my technique. I'll just walk you through some of what I do. Usually you have adhesions, especially if it's an open bypass. It's much nicer if it's laparoscopic. So I'll have the vessel sealer in arm 4, and I'll have a scissor in at the same time. So I don't have to keep switching back and forth, because there are some things that the vessel sealer does better. There are some things that the scissor is much better for. And so having both in allows me to really do that work. The next thing is to find the roux limb. If it's anti-gastric, it's such a dream. It's much easier to do this. And then I go ahead and make a mesenteric defect and divide the roux limb. And then I will take the mesentery of the roux limb, and that will take me all the way up to the GJ. And what's also nice about this is the roux limb is going to demarcate very nicely and separate the pouch from the small bowel, letting you know where to divide the GJ. So then I'm going to convert the operation to look a little bit more like a sleeve, and I'm going to get into the lesser sac. I don't want to carry this dissection all the way down to the pylorus. I want to preserve some gastroepiploic vessels, but the rest of this part looks very similar to what I would do with a sleeve gastrectomy, except that, the more medial side of the stomach, you can see a staple line there. This part is always an adventure because everyone does bypasses differently. And so you just kind of have to dissect out what you need. So now, sometimes the gastric pouch will be adhered to the excluded stomach, and I have to separate the two. This is variable. It could be super adhered. It could be very free. Sometimes they've had perforated ulcers, and it's a nightmare with thick tissue. And so this is not an operation for the faint of heart at all. You have to be very comfortable dissecting up there. So this patient had a hiatal hernia that we repaired. I won't bore you with that part. And so now you can see the demarcation of the ischemic roux limb versus the gastric pouch. Not all gastric pouches will be large like this. This one was quite large, so I had to trim it down. It's actually much nicer when it is large. And then this is me performing a hemigastrectomy just to take out the fundus. So you notice this is not your typical sleeve. And it's better to do it this way because you have less ischemia. This particular patient had a falciform in my way, so I just secure that. You could do the same thing, with the demo stitch to get the liver out of your way. So again, when you dissect out the duodenum, you want to make sure you're very comfortable doing this. It could be difficult to do. For me, all I need is a little bit of a window posteriorly, and I can pass the anvil on my stapler. This makes a lot of people nervous. I keep preaching that, I can see the anvil. You can see it right there. I think that's worth pausing. You can see the anvil right there, and the tissue in between the staple cartridge and the anvil is clearly seen. Okay, I'm gonna
So, Dr. Ayoola, if I may
please.
ask you, so you don't come down like how you normally do for a SADI DS, you just don't take down all the gastroepiploic, you just leave some of them. Now, this is because you may have taken the descending branch of the
Yes, the left gastric. So,
left
so all the
gastric.
time when people do a bypass, they've divided left gastric, and if you and right now this is living off tributaries, and so if you take all the gastroepiploic vessels on the greater curvature and the left gastric is gone, and you divide duodenum and take any bit of the gastrohepatic, you may cause that island of stomach to become ischemic.
Hmm.
And so it's important to leave some of the left gastroepiploic branches to feed the stomach. The stomach is very forgiving, has great vasculature, but by the time you've done a bypass, and now you're taking all the greater curvature vessels, you may end up having that part of the stomach die.
And you don't take your right gastric here.
I try to preserve it. The reason why I take right gastric is to get to reduce tension. And so I try to preserve it, but a lot of times I end up not being able to. So if I can, I will. I prefer to, but I'm not always able to accomplish that. And so
At this point, you haven't done your gastric fish anastomosis.
anastomosis yet. Oh, that's a really good point. So I will not do the anastomosis until I've done this dissection, because I don't want to be yanking on the stomach and yanking on that anastomosis. So I will divide duodenum first. And you see here in this particular case, I end up taking the right gastric. But I don't hug the duodenum. You see, I'm leaving a lot of tissue on the duo side, right?
Yeah.
You can see I did not hug it. You see a lot of times people do this dissection and they'll hug the duodenum inferiorly and they'll hug it superiorly. And so you're basically devascularizing the duodenum. Now, I know Dr. Pollard in particular and others are very comfortable with the blue duodenum, and most of the time it will do fine. I just think that when you're doing this with the left gastric potentially already out, that it's a little bit more scary to have a blue duodenum here, because this operation is already devascularizing so much of the gastric pouch. So I like to make sure that I leave as much tissue superiorly as I can, because I am going to divide the inferior attachments and the vessels there. So this is just a suture left on there for me to find that easily. And now I'm going to make my gastrotomy in the pouch. As I showed in one of the studies, I prefer to do a linear stapler. I'm going to make my gastrotomy in the excluded stomach. I have a VZG in there, and I'll use that to kind of suction out the bile and gastric juices. And then I'm going to use a blue load on the stapler, on the robotic stapler to do that. So I think that's one of the benefits of using the robotic platform, is when you're doing revisions, you have no idea, absolutely no idea how thick the tissue is. You have no idea. It doesn't matter what anyone says, you have absolutely no idea how thick the tissue is. And the problem is that if you are doing this laparoscopically in particular, and you guess wrong, you have an intra-op leak test that's negative, you have a post-op day 1 upper GI that's negative, and the patient will leak at about day 12 as the staple line breaks down. And so it's so important to have the right staple height. And as we all know, if you guess wrong the other way, you have a bleeding complication. So I think one of the nice things about using this platform, the robot, is that it kind of takes a lot of the guesswork out of the staple height that you should use. This is probably the anastomosis I respect the most in everything I do. So I'm going to do a 2-layer anastomotic closure. I always start out at this corner, the medial corner, because it's the corner that's hard to see. So if you start out on the lateral side or the patient's left side, it's much easier to actually not close this corner and then have a leak there afterwards. So I like to start at that corner and do a 2-layer hand zone anastomosis. It's nice when you have a really nice big gastric pouch because then you can create a really large anastomosis, and you really want this to be as big as you can make it.
Right. So
Okay.
you use the whole 60.
Yeah, if possible. It's not always possible, but I do like to use the whole 60 if I can do that.
I
The
love the
rest
technique of yours. Yeah.
Yeah, the rest of this is kind of standard DS. What I've started doing is actually doing this part first and marking with suture like this, and then counting the additional alimentary limb. If you're doing a SADI, you just count the whole way and you make your anastomosis and that's
Yeah.
it. But if you're doing a Roux-en-Y technique, then what I like to do now is actually count everything out, mark the where my ileal anastomosis would be, and mark where my DI would be, and then go
Right.
out doing the upper part. Okay. And then when I'm done, then I'll do a SADI and then drop the BP limb, if that makes sense. So I started doing that because it's easier to do this small bowel part that I'm doing right now with the patient flat. And once you stand them up, it's better to just do everything else while they're up. So that way it's just technically easier, more efficient. You don't burn any bridges by counting the bowel and putting suture on it. If you can't move forward, you just cut the sutures out and go home. So I like to start out with this part now, but back in the day, I would do the upper part first because I felt like if I could see the small bowel was free, I knew that would be able to work and we'd be able to complete the operation. So I wanted to start with what could be a rate limiting step to the operation. But nowadays, I don't feel like I burn any bridges, just counting out the bowel, marking it, and doing that, and then going back to do the top part. So here's the other technique that I've changed here.
Yeah.
I used to run a purse string suture because this defect could be difficult to close. I've posted pictures online of what I do now, where I basically fold transverse colon onto the retroperitoneum and then close the rest of the small bowel mesentery to close the defect without tension, which is the key thing, in my opinion. So you're not putting tension on that DI anastomosis. So here I'm making let me know if I need to pause at any time or go back on anything, okay?
Sure.
So
Sure.
now I'm making my
You will be
enterotomy, and that's that what I just did there is something I think is pretty important. I'm fracturing and dilating the pylorus. If you don't do that, sometimes your post-op day 1 patient will have a strictured atonic pylorus and they won't empty. And so I think it's important.
Sorry, is this only particular to your bypass to DS
Yeah.
or?
Yes, for my bypass to DS, because I feel like this is my theory. The bypass patients, especially when they're 10, 20 years old, they've had that pylorus has not dealt with food for a long time. So it's only had to let gastric juices pass through. So it could be very narrow and very small. And then when you do this anastomosis and when you do all this, now you expect that patient to push more volume through that pylorus, and sometimes it's just not going to work well. And so I've had to scope patients and push really hard to get through their pylorus post-op. And so eventually it relaxes, but you'd hate to have to do upper endoscopy immediately post-op if you can avoid it. And so for this particular procedure, I'll go in there and I'll stretch it out. For people that routinely do an upper endoscopy, I think that's great. If you do upper endoscopy in the OR, you can go in there and make sure that that pylorus is wide open. But I don't routinely do upper endoscopy, so I'll just stick in an instrument, open it up, and make sure I stretch that out.
That's a very valid point. I didn't think about that.
Yeah, a lot of these things I learned the hard way. You know, when you do that upper GI and the contrast sits in the stomach and you sit for 3 days, 4 days, patients looking at you, families looking at you, what's going on? I thought you knew what you were doing. And so, to avoid stuff like that, I will dilate out the pylorus. So, and now, it's pretty straightforward, showing this anastomosis, whether you're doing a SADI or a Roux-en-Y DS. You're going to sew this in whichever technique you like. I like to start at the corner facing me and then run it away from me. And then when I get to the end, I convert to Lambert. So I do a 1.5 layer anastomosis with a posterior row and then an inner row, but using that same suture for the inner row to come on the anterior side and do a Lambert type suture pattern to finish the closure. And then I'm going to clamp with a tip up. I'm going to push methylene blue. You could push ICG. You could do a endoscopic leak test. Take a good look at everything, make sure nothing's leaking. These days, what I'll do is all these sutures that are still sitting on the anastomoses, I'll use them to preemptively place a flap, an omental flap. So I do this now on all these patients. Okay, so I'm here closing the Peterson's defect. It's easier to partially close it and then finish off the closure after you've done your anastomosis. Again, this technique is older. Now I fold the transverse colon down onto the retroperitoneum and then use the remaining fat to close the defect. Again, I do that because I don't want to create any tension. So I think, I don't remember how this came down, but you can see every once in a while, if you're not careful, when you pull this down, you create tension on your DI. This is such a finicky anastomosis and you can see how much work I'm having to do just to get exposure. And so I just felt like this was so unpredictable that I changed my technique on doing this. Again, it's easier when you're doing a regular DS, but when you're doing Roux-en-Y to DS, sometimes this can be difficult, and you really don't want any tension on the anastomosis, and you want to have a really good closure as well. Okay, so that's why, again, I've changed that technique there, and I can send anyone that's interested the technique that I use now and would recommend.
I have Dr. Lloyd ask with a hand up. Dr. Lloyd, do you want to unmute and ask?
Yeah, I wanted to, this is phenomenal. Thank you so much for going through this. I think technically this is a very difficult procedure and you honestly make it look very simple. But my question is about the Roux limb. So, at the beginning of the video, you basically showed that you chose a spot where you were going to transect the bowel.
Yes.
Can you talk a little bit more about how you handle the Roux limb depending on the length of it? Like, where do you normally transect it? What happens if you have a super short Roux limb versus a longer Roux limb?
If you have a short Roux limb, it's actually nicer because I honestly don't necessarily measure out. I don't want to resect too much bowel at all. So I usually grab where it just looks like it'll be easy to start dissecting without going too far. So in the end, so there's no strict measurement, but I want to start it where it's just relatively free and easy to get into. Sometimes I'll have a retrocolic, retrogastric, and I will resect it at the mesenteric attachment, the mesocolon. So I'll divide it there. Now, if your Roux limb is longer than 100, you shouldn't leave it blind. You should technically put it back in continuity. But if it's shorter than 100, which most of these are, then you don't need to put it back in continuity. And that blind limb shouldn't be a problem. I'm not a fan of putting the small bowel back in continuity, regardless of what's happening, because you're creating 1 or 2 additional anastomoses. And this is already an operation prone to having leaks at your GG, your DI. So I'm not excited about making 2 additional anastomoses, number one. Number two, it takes additional time to do that. These operations, especially if it's a previous open bypass, could be 4 to 6 hours. Because if your DS alone runs you, let's say, 2 hours, now you're lysing adhesions for 30 minutes to an hour. Now you're dismantling a gastric bypass. Easily, this turns into a pretty long operation. Now, if you add 2 additional anastomoses to it, it becomes an even longer operation. So that's the part where I think that when people say you should stage the operation, if I'm going to stage something routinely, it will be staging, putting Roux-en-Y back into continuity. So I avoid putting the Roux-en-Y back into continuity no matter what. But the official answer is if it's longer than 100, you should put it back into continuity. But if it's shorter, you don't have to worry about it. You can leave it just hanging there. Now, the person that trained me, Dr. Stewart, who passed about 12 years ago, who trained me on Roux-en-Y to DS, he would resect the Roux-en-Y. If it was shorter than 100, he would actually just take it all the way down to the JJ. I prefer not to do that because if the patient has a significant issue and I need to come back, which hasn't happened, but I always worry about it, and convert to a bypass, then the Roux-en-Y usually is right there and you can pretty easily pull it up. I haven't had that happen, but I just feel bad cutting out healthy bowel. That's my short answer.
Yeah, not so sharp, but great. Thank you. So you guys have talked about like how you can get trained in all of this for just the DS and SADI. For those fellows who don't get that kind of training, how are we supposed to do it?
I think that that's a really good question. I think that a lot of times you're not going to get DS training in training. I certainly didn't. What's nice is that with what Intuitive is doing, having case obs, and people can come proctor and case obs, it really changes the dynamics of post-graduation learning. So you still have the ability to go see people that do it. I think Dr. Shariff did an excellent job of doing that when she decided she was going to do some of the procedures she had. She went and saw different people and figured out who had similar sensibilities to what her technical sensibilities are. And I think that's important. Even though I was trained in DS by Dr. Stewart, I still went and watched a bunch of other people, and I still went and I watched Mitch and Cottam and all these guys. I still went and I picked up what I liked in their technique, and I dumped what I didn't like in their technique until I figured out what kind of made sense in my brain that I could reproduce and do with a level of comfort. So I think that you should be aware of who does what. You should know that your learning doesn't stop once you're done with training. And it's nice now because there are lots of avenues to get this done. There's go to FASMBS, go to the talks, walk up to people afterwards if you like something they did, or what I like about those meetings is there are so many technical videos that you could pick things up and go up to people that obviously have an interest in teaching, otherwise they wouldn't be up there, and take advantage of those avenues. So to me, those are just a handful of ways where you can learn stuff like that.
I echo what Dr. Ayoola said. So in my training, I trained at Cleveland Clinic. So I did see some of these procedures, but they were done all laparoscopically. Now I've moved on to become a robotic surgeon, and I didn't do any of them myself like a primary surgeon. So this is where you have to understand that after your training doesn't stop. Like when you become an attending, that's actually when your actual training starts. You think you learn certain procedures, you think you know how to do a sleeve, you know how to do a bypass. But what you realize is when you're doing it on your own, it's a different ball game. That's when you have to develop a network of people you can bank on. And like I said, when I introduced Dr. Ayoola, he is mine. So anytime I have any questions, especially about SADI DSs, I lean towards him and ask him, hey, what do I do in these circumstances? And this is where the meetings that you have really help. Exactly like Ayoola said. You see something and you're like, oh, that makes sense, and that doesn't make sense, kind of thing. And not to toot Intuitive's horn, but they do a great job of getting you the resources you need. Any technique you want to learn, they'll help you find people to do so. So, and I'm sure Dr. Lloyd too has similar experiences, right?
Yeah, absolutely. I mean, you cannot underscore enough just how much you are learning when you're in practice, especially in the first, I would say, at least 2 years. Um, I am doing cases now that I hadn't done before, and these are like I'm still like several years out. So I agree with you. Yes, I do rely on my network. People who I meet when I go to the conferences, and these are like surgical giants in the field, but they're all super approachable. They're very excited about the field, and they're willing to talk with you. So I think if you're a fellow, even if you're an introverted person, you need to go out and make these connections, and start talking with these people.
And then there's an element of comfort too. So when I started this in my practice here, none of my partners were doing this. So when you start and you think, oh, you have your partners to help you out, that's not necessarily true. So you might bring in a new procedure. So I remember I spoke to Dr. Ayoola and I said, make sure you have your phone on you. Remember that? I said, I'm going to FaceTime you if I get into problems. So that's where you can kind of bank on people to help you out, and there are quite a few people who are willing to help you with this.
And the other thing I would add to all that is, record your cases.
Oh,
Please record your cases and not just record them, but go back and watch, because you do the best learning when you're not under the pressure of trying to finish the case, but you're at home with a glass of wine, you're relaxed, you're out of the OR, you're safe now. And that's when you can actually watch and you can see where you were inefficient. You can see where you created a problem. You can see, and what's weird is that it's just like game film, because then when you're operating, you remember that training and you can do things differently. And I also think it's important to watch other people's video, because I had an attending that used to say the mind can't see what the mind can't see what the eyes haven't. And so you don't realize what you're picking up as you're watching other people's videos, where you're just like, ooh, I remember I've seen this before. I could do this in this situation. So watch your videos, watch other people's videos, and you just never know when that stuff will come in helpful.
I want to jump in here. I know you guys are doing a phenomenal job, but there's a question that popped up in the Q&A, if you guys want to address that.
sure.
Someone
Sure.
asked about weight regain after SADI-DS. What have you seen? What's in the literature kind of situation?
Yeah, like how do you manage those patients?
So I have seen maybe in 12, 13 years, maybe 2 or 3 patients that have weight regain after DS or Roux-en-Y to DS. All those patients have a sugar addiction, and they'll tell you up front. They just love sugar, bread, soda, sweet tea, stuff like that. It's just liquid sugar. And I tell those patients that we have to figure out a way to get them off that liquid sugar, because there's no way to beat that. If you consume it, there's no way to beat that. The good thing about the DS, what I found is, unlike the bypass, if they go back to a protein-heavy diet and lay off the sugar, they still lose weight. So the operation doesn't break, because I find with sleeve or bypass, once they gain that weight, even if they go back to the diet you recommend, they don't go back and lose it. And so for those patients, I have them work with behavioral therapy, and I put them on weight loss meds to try and curb their sugar appetite. And some of them will follow through with that and do well, and others just won't. And I tell them we've reached maximal medical therapy. There's literally nothing else you can do. I had a patient one time that said, hey, can't we go back in and shorten my common channel more? And I said, nope, no way. I would never do shorter than 100 common channel on a DS patient. Conversely, I would never do longer than 400 total alimentary limb, because I've had patients come see me, and this is to that question. I had a patient that had a DS, not a Roux-en-Y DS, but a DS, came and saw me and said, I didn't lose weight. And that was the first red flag. That doesn't sound like a DS to me.
Right.
So it wasn't like they lost and regained. They just didn't really lose weight. They lost weight, what sounded like a poor responder sleeve. So I took them back to the OR to go count their bowel limbs, and their common channel was 250, and the Roux was 250. So they had a total alimentary of 500. So they were basically a bad sleeve because there was a lot of fundus left up there too. So I think that if you hear a DS patient, especially primary DS patient, say they didn't lose weight, it's not unreasonable to do a diagnostic lab and go count the bowel, because the op report for that patient said 100 common channel, 150 Roux. But that's not what I found.
Oh,
And
wow.
I counted it like 3 times because I couldn't believe it. I had the entire staff counting with me as we counted multiple times just to make sure. And it was difficult to reconstruct that patient, and they lost weight afterwards. But again, even if the op note says the DS was done standard, I will offer a patient a diagnostic lab. I had another patient that I did the same thing. I did a diagnostic lab, and their common channel was 130, or just a little over 100, and their Roux was 150. I did nothing for that patient because to reconstruct that, just to give them 20, 30 centimeters less bowel, to me was unreasonable risk. I explained that to him after the diagnostic lab. We had a long conversation about it, and the patient agreed, and we decided to do weight loss meds and other things like that. But again, we only have so many options in our armamentarium. Once you exhaust them, there's nothing else you can do.
So I have two questions for you. First one, how do you code for these? Like, because I do have a patient that had a DS somewhere in Minnesota, and I forget, but precisely what you said, like they had a weight loss and then they gained their weight. So I'm thinking more like a sugar addiction. But how do I confirm that what the bar lengths are? How do you code for that? Is what my question is. Like, what do you?
Yeah, usually I end up doing a diagnostic lab. I forget what the code for that is. Now, if I do anything else, but usually when I do that, it's just a diagnostic lab. Now, sometimes I'll talk to the patient ahead of time that, hey, I'm gonna go in there. If I find an issue, I'm gonna address it. And so what I end up doing a lot of times is still billing for the DS unlisted. And other times, if there's an issue, let's say it's Medicare or something, I will bill for each individual thing I did.
Okay.
Enterostomy, small bowel resection, partial gastrectomy, small bowel anastomosis. I would just list, it'd be like this laundry list of things I did because there's no code for laparoscopic DS.
Right.
There's an open code for DS, and every once in a while, Blue Cross Blue Shield or some of these others will insist I use the open code with a modifier. And I'll have a conversation with them to say, hey, I don't want you to turn around and saying this is fraud because I did it laparoscopically. But most of the time I'll use the unlisted.
So when you have a conversation with the patient, you say, hey, listen, I'm going in, I'm going to count the limbs. If there is something I can do, I'll do it at that time. Otherwise, I'm just going to come out.
Yes, and my words are, I am going to go in and turn whatever you have to what I do. So this is what I do. Under a common 150, this, a sleeve that looks like, this is an Ayoola DS. I'm going to go in there. I'm going to look at it. If it doesn't look like my DS, I'm going to make it look like my DS, because that's why you came to me, because you want me to give you what looks like what my DS looks like. And so that's what I'm going to do. If it doesn't make sense to do that, then we're going to reconvene and I'm going to tell you what I found, because there is no other way to know what the bowel limbs are. CT is not going to tell you. No imaging is going to tell you, and endoscopy is not going to tell you. The only way you're going to know is you got to go count it. You got to go in there and you got to go count it. And no patient wants to hear they need 2 operations, but I tell them that's still a possibility, because if I go in there and what I find is not something I feel comfortable messing with, I'm going to wake you up and we're going to talk about it. But most patients will have the conversation and say, yes, Dr. I'll make it look like what you would do. And if we're able to do that, then we're good to go.
Okay.
Sometimes I'll get in there and it won't be a bypass. It'll be a VBG.
Oh,
Sometimes I get it, especially
very thought, oh my God, I never hope to see one.
Yeah. One time I went in there and it was like a loop bypass, so you just see all kinds of things, because patients sometimes don't even know what they had.
That is true. That is true. Now, before I keep asking questions, and I can ask questions all night long, does Dr. Poon, do you have any question? Dr. Paul, do you want to ask any? Make sure there is nothing else in the chat.
There's one thing in the chat about dietitian. Do you have a specific dietitian who knows your way of all of this? Or
I have gone through a handful of dietitians, and some of having really good and done their work, and others I had to point them in the direction to get information. And I think it's important that people don't just assume that that all bariatric procedures require the same diet and the same approach. It's also a problem you will face if your patient gets admitted to a hospital that's not yours. The dietitian sees them and says, you know, this is what you should eat, and it could be wrong. I think the DS is one of those procedures where you have to do a lot of work to make sure the patient has an understanding of what they need to do, and you have to disabuse them of the general tendency we all have, and patients in particular will have, of, oh, all healthcare providers know what I need and how to take care of me, so I don't need to know anything, they know it. And so I tell patients having a DS, you need to know this stuff. Do not expect anyone to save you. You need to be able to save yourself. So when you go to the hospital and they say all you need is 50 grams of protein, you need to raise your voice and say, nope, that's incorrect. This is what I need. And I try and give them resources to be able to do that. I send letters to their primary and so on and so forth. But I like to use models in other health fields to describe what I'm talking about. Transplant patients have to know this stuff, right? They have to know their stuff. They need to know these are your immunosuppressives. If some doctor says, oh, you don't need these medications, you need to be able to say, oh, yes, I do, right?
Yeah.
So there's a lot of training so that the patient is armed. You have to do the same thing with a DS. Lap band, you didn't have to do it as much. Sleeve, you certainly don't do it as much. But the more aggressive you get, distal bypass, duodenal switch, now those patients really need the knowledge because our colleagues just don't know enough.
So I want to ask you one question. Now you've decided you're going to convert this bypass to a DS, right?
Mm-hmm.
Walk me through what your workup's going to be. Are you going to do a endoscopy to see how
Yes.
big the pouch is?
Yes.
What
Check their lab work. I think that's probably the biggest thing. The other thing you can do is get a CT scan with IV contrast to make sure you can evaluate the vasculature. I haven't really seen that be an issue. I think the biggest thing is pouch size, because that if the pouch is super small, you may be forced to use an EEA stapler and risk a higher risk of stricture, but there'll be no way to get a linear stapler in there. So you'd have to use either a circular stapler or you would have to hand sew it. And that's good to know ahead of time so you can counsel the patient. I've had a conversation. I just saw that message from Isabel. Thank you. Noted. I've had patients that are from out of town that will have their endoscopist locally do it. I hate that. I prefer, they don't want to come down just for endoscopy and then come down again. So why can't I just get it? So sometimes I'll allow that, but I don't like it because I really want to know what I'm dealing with. If you don't like excitement and you want to just do 10 sleeves every day, stick to that. Don't do Roux-en-Y to DS. If you like excitement and fixing jigsaw puzzles and unexpected things happening to you and wishing you were never born and wondering if you ever get to leave the OR, then do this operation, because sometimes you get in there and you just meet stuff and you have to figure out, am I going to quit, or am I going to, how am I going to solve this? And I'll tell you that that's the operation that you just really never know. Antigastric could be super easy. Retrogastric could be miserable. Previous ulcer that they didn't tell you they had, that perforated, that they just forgot to tell you, can make the case very miserable. So there are all these different things. Previous procedures, if they've had sclerotherapy, if they've had different things happen, and patients, as we all know, could be terrible historians sometimes. So it's not that they mean you harm. They just didn't remember to share that with you. And then you get in there and you're dealing with a mess in there.
Yeah.
So I would say the upper endoscopy is critical. If you can do it yourself, that's the best way. I would say if you're worried about vasculature, I know there are people that routinely get a CT with contrast. The other benefit of getting a CT with contrast, and you'll be surprised, especially if you see the patient has had a bypass revision. So if they have a bypass and then they've had a bypass revision, you should get a CT, because there are a group of people that were resecting the excluded stomach when they went back for bypass revision, and the rationale was that it would reduce ghrelin, right? So they would go in, exactly. They go in and they'd resect the rest of the stomach. So you go in there and you're looking for excluded stomach and you keep seeing pancreas. Don't dissect out pancreas. Don't dissect that out. Just know that someone beat you to it and they've resected the stomach, and that patient is married to a bypass for life, and there's nothing else you can do about it. I had a few patients that had enough of antrum left that I could do a small bowel interposition. One of them did really well. The other one, we got to go back and convert her back to a bypass because she couldn't tolerate what she wanted to. Which before I did it, I looked to make sure it had been described. But yeah, that's the benefit of a CT, to make sure that the excluded stomach is not resected, because if it is, there's no way you're going to do an operation. And usually the tell is if they've had a previous bypass revision.
Right.
That's a red flag.
I know it's our time, but I have to ask you this one dying question.
Sure.
And it's actually a patient that I'm dealing with. So this patient had a sleeve and no problems with the sleeve. Now BMI of 51 or 52, but Dimitri score of 74. So has acid reflux. Can be managed with medications, no hiatal hernia. DS or a bypass?
So
50,
I think,
BMI 50.
yeah, so I think one of the big questions to answer is there something wrong with the sleeve? If there's something wrong with the sleeve, kinked, twisted, just abnormal sleeve, then I would bypass for sure. If there's nothing wrong with the sleeve, I would counsel the patient. I would let them know the data, and the general feeling is that the bypass is probably the safest thing for reflux, but it won't do much further. So I would say that your option, if you're going to do a bypass, is just do a distal bypass. Have a 400 total alimentary limb length minimum, have a common channel that's over 150. I would say if you could do 200, that's probably a reasonable thing to do. So they'll get pretty good benefit from the bypass if you do a distal bypass. I think that if you decide to do a DS in that patient, what you're hoping is their significant weight loss will address the reflux. And what you're hoping is that when that sleeve caliber and kind of shape changes, that they'll do better. So I would say that the textbook answer is a distal Roux-en-Y. If you know that would probably be the textbook answer for that difficult patient.
All right. Dr. Ayoola, I could pick your brain all night long. I mean, this is awesome. Thank you so much, Dr. Poon. That was a very good summary of the literature, and we will see you guys next month. Thanks everyone for joining us today. Speak to you guys soon.
Thank you for having me. I appreciate it.
Thank you.